Dr. Ross will be presenting from Task-Oriented to Infant-Led Feeding, State of the Science, Part 2. Thank you, Dr. Ross.
Thank you, Sandy. I'm excited to present Part 2. We've had great interest and feedback on Part 1. My intention in providing this three-part webinar is to present information to professionals on the research and the science behind the interventions that we currently consider when supporting infant feeding in the NICU. Before we get started today, I want to swing back and revisit the information presented during Part 1 on the effectiveness of the N-trainer. In reviewing this section, I want to ensure that the information presented was not unintentionally misleading. It is my main intention and sole objective to present the state of the science clearly. In the context of my discussion of Barlow's 2014 publication, as shown in Figure 6 and stated by the authors on page 4, chronic lung disease infants given the pulsed pacifier treatment stayed in the NICU for a significantly shorter period of time compared with chronic lung disease infants on the sham pacifier by an average of 2.5 days less. That was significant at the p less than 0.05 level. The authors go on to state that respiratory distress syndrome infants receiving the pulsed pacifier treatment remained in the NICU 4.3 days longer than RDS infants on the sham pacifier, which was significant at the p less than 0.01 level, and this information is stated on page 4 of the publication. Information seen in the bar graph from Figure 6 shows that while the mean length of stay for the infants in the healthy preterm cohort was slightly longer for infants treated with the pulsating pacifier, this difference was not statistically significant. So now let's move on to Part 2 of this webinar. And Sandy has already mentioned the objectives for this part of the webinar. I have the same disclosures as I had in Part 1. I'm aware that we may have people joining us today that did not attend Part 1, and so I wanted to revisit a few of the slides briefly before we move on to new content. The pictures in this presentation are provided with gracious permission from the families that I've worked with for the express purpose of trainings conducted by myself, so no reproduction in any form is allowed and would be considered a HIPAA violation. Also, the content of this presentation is presented with the utmost respect for the scientists who have contributed to the state of the science. The critical review of this science is intended to provide practitioners with information with which to inform our practice. Thank you to Handi-Craft for providing this forum for neonatal practitioners to learn and to reflect upon our own practice. And thank you to all of the researchers as well as bedside practitioners who work diligently to improve feeding and feeding outcomes for infants in the NICU. So as I mentioned during Part 1, one of the first things we need to consider is what we're talking about, because feeding and nurturing both have definitions related to more volume. And I really believe that we need to be thinking about nourishing and fostering the development, in this case, of both infant feeding skills and the parent-child interaction, which is in large part the focus of Part 3. When thinking about moving from task-oriented to infant-led, we spoke briefly already about perspectives and outcomes related to task-oriented feedings. Now we're going to shift our focus to more infant-led feedings. And so what you will see in infant-led feedings is primarily interventions are now shifting to supporting physiologic stability and what we call, quote, quality, which of course is difficult in some cases to describe. We all know what quality looks like, but how do you define it? Once again, I want to make sure that we're all putting this information in the context of what we know about normal development and what are the generalized risk factors. So from the Van Nostrand study in 2015, just as a reminder, in general, the outcome data is showing a mean postmenstrual age for attainment of full oral feedings at about 36.5 weeks. Also from the Pickler study that we discussed in Part 1, regardless of whether you institute oral feedings earlier versus later, there does not appear to be a significant relationship to the postmenstrual age at full oral feedings or length of stay. So we have spent time looking at the task-oriented feedings in part 1. Today we're going to be spending more time looking at the data that we have regarding infant-led feedings. And the theoretical foundations are slightly different in my mind, and I want to give a nod to the American Physical Therapy Association and certainly to Dr. Jane Sweeney, who in rewriting their NICU practice guidelines looked to these two theoretical foundations as well. So the theory of neuronal group selection was proposed by Edelman in 1987, and we will talk about that in more depth in part 3. The theory of synaptic organization of behavioral development I'm going to introduce in this section, and then we will also revisit in part 3. So the synaptic organization of behavioral development was proposed by Dr. Heidelise Alls in 1982. And in this, she's really talking about the process of behavioral organization and the fact that it is a process, it's an ongoing process, and that there are different subsystems that interact and are interdependent. Behavioral organization really is a foundation that supports the infant in responding to the challenges presented when they're born preterm. Caregivers observe and respond to the infant's behavior, which reflect the current functioning of the infant. It is how the infant expresses their current state. I do actually want to clarify the neonate includes not only preterm infants, but also certainly newborns, healthy and ill. Physiological stability is the foundation system in the synaptic organization of behavioral development, and it supports organization of all of the other systems, which include movement, behavioral state, attention interaction, and self-regulation. And I wanted to briefly go over this theory because as we start moving towards infant-led feedings, you will see that the focus has been shifting from volume to really stability during feedings. Organization or disorganization of any one of the systems similarly will influence the other systems through the process of synaction. Infants who are organized are able to reach a level of homeostasis that then supports their striving for the next challenge. And in this case, the challenge is feeding. So let's start talking about infant-led feedings and what do we know about infant-led feedings. For this presentation, infant-led feedings refer to feedings that focus on one or more of the following: improved physiologic, motor, or behavioral state stability, gestational age at full oral feedings, and length of stay in terms of outcome measurements that are always being looked at whenever we're looking at interventions in the intensive care nursery. In addition, typically interventions that focus on infant-led feedings have included breastfeeding, positional supports, slowing flow through a variety of avenues, pacing the feeding in support of stability, and then cue-based or infant-led feedings. And we'll talk a little bit about a distinction that I make that certainly is not necessarily shared by everyone, and we'll talk more about that. So when we look at breastfeeding, I want to put out there, much like Dr. Suzanne Thorey, I focused on bottle feeding primarily because that's where infants have the most difficulty. That said, I want to bring us all back to the concept of that breastfeeding is really a relationship, and it is the relationship that should be our primary focus. And currently, breastfeeding definitions really focuses on breast milk delivery as opposed to how the infant is being fed. And as Noel Weiss has pointed out, it seems that the breastfeeding relationship is not considered in this definition. Breastfeeding is the ultimate infant-led feeding program, if you will. So I do want to just point out a few wonderful articles in this section before we move on to bottle feeding. So in terms of breastfeeding, these 3 studies primarily were looking at breast milk delivery, and you see even with just getting infants to be exclusively receiving breast milk at discharge, in Japan they are reporting outcomes of about 22.5% of infants exclusively getting breast milk at discharge, and they define breastfeeding as receiving 100% breast milk either through breast or through bottle feeding, which certainly shows that they have a way to go, as do we in the US. You see that in the Dowling study, about 45% of infants when they discharged were receiving exclusive breast milk, but within that percentage there is no indication of how many of those infants were actually breastfeeding. In the Pineda study, what she points out is that only half of infants ever even have the opportunity to breastfeed in the intensive care nursery, which certainly means that we can improve our support and should improve our support in helping babies and mothers achieve this wonderful skill. So when we look to other countries, what we see is that there is hope, if you will. So in the Ackerstrom study, this study, when they talk about breastfeeding, they're talking about direct breastfeeding. They're not talking about receiving breast milk. And you see that actually it is possible for infants to go home breastfeeding, and about half of their 32 to 36 week infants were in fact exclusively breastfeeding. Certainly that number drops if the infant was less than 32 weeks at birth. In a recent review by Lucas and Smith, I want to point out that there are some data to support that infants who are born preterm actually do significantly better across a number of outcomes than infants who are bottle fed. So one study that looked at resting energy expenditure showed that infants breastfeeding had a similar resting energy expenditure than those bottle feeding, and the gestational age of the infants in that study was less than 32 weeks at birth. Weight gain has been shown in 2 studies to be slightly less than with bottle feeding, but in 3 studies the weight gain was similar, and in those studies the gestational age of infants at birth was 27 weeks. 6 studies showed that infants have fewer desaturations with breastfeeding than bottle feeding. 1 study reports increased temperature. 5 studies report more stable respiratory rate and heart rate with infants when they were breastfeeding. And then 3 studies done with infants born at 27 weeks, as young as 27 weeks, I should say, show that infants, in fact, were able to root and latch as early as 28 weeks, and to show some sustained sucking as early as 32 weeks. In these studies, breastfeeding was achieved by 35 to 36 weeks postmenstrual age, and that referred to exclusive breastfeeding. One of those studies was done by Dr. Nyquist in 2008. And in this study, you see with 15 infants born between 26 and 31 weeks postmenstrual age, they initiated breastfeeding at a mean of 31 weeks with a range of 29.6 weeks up to 33.6 weeks. In doing so, they used a semi-demand feeding schedule with a 24-hour prescribed volume target, and they used the preterm infant breastfeeding behavior scale to assess the infant's feeding daily. What you see when you look further down in the table is that all 15 infants achieved full oral feedings. The mean was at 35.7 weeks with a range of 32.6 to 38.7, and attainment of full breastfeeding was achieved at a similar median, and you see the range. So one of the things that I try to step back and think about is that I certainly was of the opinion when I first started in the intensive care nursery that infants who were preterm actually would go home sooner if they were bottle fed. And in fact, in places where breastfeeding supports are prevalent, I would say that the data doesn't support that. Dr. Nyquist in 2013 actually presented a number of myths about breastfeeding in the NICU, and I encourage everyone to pull this article. And I do want to just point out I have been making some changes to the reference list, and it will be posted at least by the end of part 3. And the changes are related to basically the feedback and the questions that we've gotten on part 1. I've been making changes to part 2 and part 3 to respond to some of those questions. So that said, in Dr. Nyquist's 2013 article, she addresses myths about breastfeeding in the intensive care nursery. And what's wonderful about this review article is that she then also provides the data that we have to dispute these myths. And so I encourage you to take a look at that. I believe that one of the reasons why we don't believe that infants can breastfeed well in the intensive care nursery is simply because we don't give them a chance. So now let's start looking at bottle feeding and at programs that are more designed for bottle feeding in the intensive care nursery. So the Neonatal Oral Motor Assessment Scale by Marjorie Meyer Palmer in 1993 was an early attempt to shift the focus from quantity to really the quality of the feedings. It was still primarily motor-based with a focus on assessment of tongue and jaw movements, but very holistic in terms of looking at quality indicators, I guess I would say. There was also a focus on the predictive nature of feeding, and some of the NOMOS psychometric qualities have certainly been called into question with 2 very nicely designed studies. Another step in this direction are the infant-driven feeding scales by Ludwig and Weitzman in 2008, and they really have focused our attention on documentation of 3 components, not just 1. The first is using infant readiness cues to determine whether the infant is ready to attempt an oral feeding in an effort to move away from feeding on a purely scheduled protocol. They also have quality indicators that are used to help document success, and these are really focusing our attention on physiologic stability, and we're one of the first ones to do so. And then a third is documenting caregiver strategies that were used during the feeding so that caregivers can be more consistent. Wellington in 2015 published information on a historical control study. Basically, in their nursery, they have moved from protocol-driven to more infant-driven feeding approach using these scales. In the protocol-driven feedings, you see that the order was written by the neonatal nurse practitioner or the neonatologist, and really infants were progressed in a stepwise fashion based, as you see, on finishing the bottle. So as they point out on page F1, this approach did not incorporate feeding cues from the bottle. It was outcome-oriented, whereby a good feeding was equated with a finished bottle. Infant-driven feeding approach, according to the authors, relates to the infant determining when and how much to nipple feed, with the remainder provided via a gavage tube, and emphasis is placed on the quality of the feeding rather than the quantity ingested. And you see for all of these, for the 3 age groupings that the authors chose, IDF relates to infant-driven feeding, PDF relates to protocol-driven feedings, and in fact, for all of these 3 age ranges, the differences were statistically significantly younger achievement of full oral feedings. There are a number of interventions that are more isolated, that are focused primarily on stability. So we'll go over those now as well. One is elevated sideline positioning. And the data regarding this is somewhat evolving, if you will. In the most recent study by Park, they had only 6 babies, but it was a crossover design. That was Park in 2014. In the Clark study in 2007, similarly, they had 6 infants and it was a crossover design. Both of these studies showed a significant improvement in physiologic stability. In the Dawson study, what they show is that infants, by the time that they were 35 weeks post-menstrual age, had no statistically significant difference in their physiologic stability when they were being fed either in sideline or in cradle hold. The Lau study in 2013 and the Jones study in 2008, both were focused more on the outcomes of post-menstrual age. The Lau study included outcomes related to volume, and they did not find that sideline position changed outcomes in any of those areas. When we look at the support of slowing the flow or self-pacing bottles, the information is somewhat different, again, based on what the outcomes are looking at. So Aishima's study in 1991 showed an improvement in oral motor movement patterns with this slower flowing. The Lau study showed no differences in oral skills that were related to volume, efficiency, and proficiency by the end of the acquisition process for full oral feeding. The Shield study showed that there was no difference in the rate of milk transfer, so again, more volume oriented. In the Chang study, they found that infants took more volume in less time and were more efficient when fed with a regular versus a cross-cut bottle nipple, and it was a crossover design. The respiratory rate and the oxygenation was slightly higher in the cross-cut nipple condition, and that was statistically significant, although I question whether it is clinically that relevant, and I think both have to be considered. In the Futilli article in 2009, they used a self-paced bottle, much like they did in the Lau study of 2015. And in both of these studies, you see improvements with the self-paced bottle, with improved overall intake, a greater percent of infants who finished their full feedings, feeding durations that were shorter, stages of sucking that were considered more mature, and frequency slowing over time, all being statistically significant in the Futilli study, and improved percent of volume transferred, milliliters per minute, and proficiency seen in the Lau study. Both of those 2 studies, though, are really focused primarily on outcomes that are more task-oriented. When we look at pacing of feeding, the Lau-Morstat study in 2003 shows an improvement in physiologic stability and in development of more efficient sucking patterns at discharge using the NOMOS as an outcome measurement with no change in discharge or average weekly weight gain. But one of the things to note is these isolated interventions, we don't have a lot of data. The data isn't as strong as we would like, and hopefully there are many of us who are looking at building that body of knowledge. So as we look at the information that is available that focuses not on isolated interventions but on more holistic interventions, I want to take time to talk about how I think cue-based versus infant-led feedings are slightly different. We know that feeding programs are now beginning to emerge that are describing not only initiation cues but stop cues and stopping based on infant behaviors rather than based on volume. And certainly the programs are including infant instability and fatigue as stop cues, respecting that the infant who is tired should not be pushed to finish the bottle. For the context of this presentation, I state that there is a difference between cue-based and infant-led feedings, but remember that distinction is not consistent in the literature, and that is perfectly fine that we all think of this slightly different. Cue-based feedings, the way that I think of them, refer to feedings offered based upon behaviors or cues and are stopped based upon cues. Infant-led feedings differ in that the caregiver is making decisions and changing their support and interactions based upon the behaviors of the infant, and it's really an ongoing process. So infant-led feedings also, in their true sense, I would say imply that the infant is setting their own schedule of feedings as they become capable of doing so, and for instance at the start of oral feedings in many cases, rather than the infant being offered feedings on a schedule. So as we start moving towards the understanding that what we do as caregivers is directly influencing the ability of the infant to respond to the challenges, the early feeding skills assessment in 2005 started really to look at this process quite holistically. It's a documentation for describing the quality of the feedings, and quality is better defined. There's documentation using the EFS for readiness for feeding, the tolerance of the feeding, and the developmental stage regarding the ability to remain engaged in the feeding, which is one of the first times we see the infant, the focus being on an infant being an active participant in the feeding. Regarding organization of the oral motor functioning, coordination of swallowing with breathing, and maintaining physiologic stability. The EFS also encourages the caregiver to attend to the environment and proactively set the stage for successful feeding by thinking about the feeding environment, selecting an appropriate feeding time, assessing baseline stability of the infant, providing developmentally appropriate supports for the infant during the feedings. And so this is now the beginning of this evolution. Gail McCain in 2001 was providing some research support for these concepts, and in this study, there are several of them, but this is one of her studies with 81 infants born at 32 to less than 34 weeks at the start of the feeding protocol. Oral feedings were offered contingent upon the infant's behavior of alerting to at least a drowsy level. If they did not alert, they were offered non-nutritive sucking, and alertness was reassessed. So there was a window, if you will, plus and minus around the scheduled feeding. If the infant was alert, they were offered an oral feeding, and if not, they were gavage fed. Feedings were stopped based on infant fatigue if the infant stopped sucking or the infant became unstable. And I want to take time and pause and ask ourselves as clinicians, when an infant is showing signs of fatigue or if the infant stops sucking, do we as feeders respect that communication skill? In this protocol, the remaining volume was gavaged if necessary, and using this protocol, the semi-demand feeding or the semi-demand method shortened the time for infants to achieve oral feedings by 5 days with no differences in weight gain. So the outcome was still more task-oriented, but the concept was really incorporating the infant's communication to the feeder. Dr. McCain in 2012 did a similar study, this time with infants more fragile, with infants with bronchopulmonary dysplasia. The experimental infants were fed every 3 hours dependent upon alert behavioral state and non-nutritive sucking. So again, there was a schedule imposed. Feedings were again stopped when the infant fatigued or had physiological instability. And control infants were advanced per a preset protocol. What you see in Table 2 from the article is that indeed infants fed with the experimental protocol achieved full oral feedings in a shorter interval time, and in addition to that, you see that males took longer than females, and in terms of supplemental oxygen, if infants were still on oxygen at the time of the initiation of oral feedings, those infants also took longer to achieve full oral feedings. Dr. Puckett in 2008 presented information that was less structured, I guess, in terms of the scheduling, which is a good thing. So they set up a protocol where infants were fed based on feeding cues, and you see them listed on the left side of the table. The feedings were stopped based on satiation cues, and that is on the right or the middle of the table. They also kept track of number of adverse events, which include apnea greater than 20 seconds, oxygen saturations if they fell less than 85%, and heart rates less than 80 beats per minute. And in doing so, they eliminated any true schedule in this study. They found no difference in weight gain, although I do want to point out that 12 grams per kilogram per day is suboptimal. So both the control and the experimental groups had similar weight gain. The average length of stay after enrollment into the protocol was shorter for infants in the experimental protocol. The average total number of adverse events, I think, actually tells the biggest part of this story in my mind, with experimental babies having approximately 4 times fewer adverse events than those in the control group. They were similar gestational age at the time of study entry. At the time of achieving full oral feedings, the control babies were older than the experimental babies. And so in red, you see the outcomes that were statistically significant. They also had no difference in nurse-patient ratio, which I thought was interesting. So as we move here towards changing caregiver behaviors based on infant behaviors, I want to acknowledge one of my mentors, Catherine Shaker, who in 2013 described this concept, I think, beautifully. When an infant is perceived as having meaningful behavior, i.e. communicative intent, the focus changes from a volume-driven to a co-regulated approach through which the infant guides the caregiver, and this is cue-based feeding. So I would consider that infant-led feeding, and but that holistic nature is really what we're now shifting our focus to. So Suzanne Thorey, who is also one of my mentors, published on an approach, a feeding approach called Coreg Approach, which was designed to enhance the assessment of feeding changers and to respond on an ongoing basis. And so caregivers respond to behavioral, auditory, physiologic feedback of the infant, and based on the infant's communication, the caregiver provides rest breaks or opportunities for breathing, decreases the flow of milk by adjusting the sucking burst length, which would be similar to pacing, responds to loss of milk with resting periods, and decreases the feeding demands at the earliest signs of behavioral disorganization. Other principles of developmentally supportive care are included in the Coreg approach, and these are sideline position with postural support, preparation of the infant pre-feeding, initiation based upon infant readiness, and minimization of movement during feeding and burping. You see in this study, 20 infants born at less than 32 weeks post-menstrual age were enrolled, and there were 75 feedings total that were part of the data collection, 40 with usual care, 35 with co-regulatory care. In the Coreg approach, what they found was that when infants were fed using the Coreg approach, there was more frequently a preparation for the feeding. So all of the necessary equipment was available, minimizing the disruption that can occur when the infant needs to be set down for changes in bottles or those sorts of things. More commonly, the feedings were started because of infant readiness cues. Infants had more rest periods and breath regulation events and had fewer sucking stimulation events. Infants also had less oxygen variability, oxygen decline, and time spent in desaturated states with less heart rate fluctuation and declines, less behavioral disorganization, better fluid management, and less observed effort to breathe. So really, the concept of responding on a moment-by-moment basis during a feeding is highlighted in the Coreg approach. So another approach is one that I've developed called the Supporting Oral Feeding in Fragile Infants, the SOFFI method. And in 2011, Dr. Philbin and I published this from a theoretical standpoint. We really present feedings as an interactive process. Caregivers must assess and address the infant's physiology and behavior throughout the feeding. We also feel like caregivers must be conscious about their decisions during a feeding and focus on the stability of the feeding, and that quality is going to lead towards quantity, and we need to focus on enjoyable feedings. In 2013, Dr. Sabelspouse published the Infant-Directed Oral Feeding for Premature and Critically Ill Hospitalized Infants Guideline for Practice out of the National Association of Neonatal Nurses. And in that publication, she stated, to optimize the use of this guideline, it's recommended that the Supporting Oral Feeding in Fragile Infants feeding algorithm be used concurrently. And the use in conjunction with their guideline is highly recommended because they're grounded in similar principles. So as a free disclosure, as I disclosed at the beginning of this lecture, this is a program that I've developed and that I currently teach. So there are two studies that have come out that have used this approach, most recent being the one by Hannon in 2015. Now, there were probably other things in play, but in this research study, the authors purport that the infants were fed by SOFFI method trained staff using the SOFFI algorithm and the feeding program that is taught during the SOFFI method trainings. This study focused on questioning whether infants who were less stable, specifically infants with BPD, could be fed using their baseline stability as a guide for initiation of feeding. And so this is a group of children that I talk about in the training as stably unstable. So we know that they have medical instability, but from a developmental standpoint are at the age where now biologically they would be expected to start oral feedings. And is there a way that we can look at those infants who are stable in their instability, use that instability as a baseline, and initiate oral feedings with the understanding that feedings need to stop at the first signs of distress so that feedings can be pleasurable and the infant can progress at their own state. And so you see that these infants were in fact all term at the time of this study. 26 infants were orally fed while on nasal CPAP, and 27 infants were not orally fed when they were on nasal CPAP. So the infants needed to transition off of CPAP before being offered oral feeding. The intervention, the infants were fed by an occupational therapist 1 session per day, 3 to 5 times a week for at least 10 sessions or more until they fully weaned off of nasal CPAP. So you see that there was a lot of safety supports in this study. Cardiorespiratory rates, rhythms, and coordination were monitored, and feedings were stopped based on instability. The therapist also assessed the infant's behavioral and physiological responses before, during, and after the feeding, and these were all documented. They also kept track of heart rate, respiratory rate, oxygen saturations, as well as episodes of coughing, gagging, increased work of breathing. Feedings were discontinued if the infants exhibited difficulties, so increased respiratory rate, decreased oxygen saturations, bradycardia, coughing, gagging, or other behavioral signs of distress such as tongue thrusting and arching. They also had to demonstrate appropriate neural behavior for matural age. There were no differences in demographic or clinical characteristics. So what they found was an earlier acquisition of full oral feeding in the nasal CPAP orally fed infants with a median number of days of 17, and that was statistically significant. Also, infants achieved full oral feedings at a younger postmenstrual age, and that was statistically significant. No clinical significant aspiration pneumonia was documented during the period of the oral feeding, and infants feeding while on nasal CPAP were monitored, and 58% transitioned off of nasal CPAP while they were at the same time learning to eat. Length of stay was not significantly different, neither was rate of readmission. Safety measures, what I really want to point out is that the researchers were documenting the number of apneic or bradycardic episodes for infants being fed while on nasal CPAP. And so when looking through this, you can see that most of the infants actually were fairly stable, but that the researchers stopped the feedings based on instability, and I do want to make sure that we all understand that. We also see that they stopped if there were behavioral or physiologic distress during the preparation even for the feeding, and in that case the infant was given a pacifier and held. They were not offered the oral feeding. So that is one study about, or that uses the SOFFI method. But so far we haven't talked about any studies that were intervention studies that looked at outcomes post-discharge. And I want to wrap up this section by looking at moving forward into post-discharge, because we know that many of these infants have feeding problems after discharge. Most infants who are moderately preterm are able to go home without needing a supplemental tube feeding, although certainly the Jed-Churla study points out that it does make a difference how early born they are. In the Jed-Churla study, they had extremely preterm infants as part of their population. In 2014, Lane published data out of Australia, and what they're finding is an increase in readmissions for feeding problems after discharge in the NICU population, an average of 3.5% per year from 2001 to 2009. In a review article that I wrote with one of my other wonderful mentors, Dr. Joy Brown, in 2013, we know that earlier born preterm infants are later at achieving full oral feedings, but after discharge, preterm infants are slower to develop eating skills, and parents report feeding problems are quite prevalent. The migraine study in 2013 shows that infants, as they're getting older, have a worse drive to eat score and lower food repertoire score. The Tirola study in 2012 points out that infants born preterm, when observed in that transition to oral feedings, the feedings are prolonged and messy. The pace of the feeding is rapid, But because much of the food drops out of the mouth, the feedings often take actually longer. These infants have increased sensitivity to texture, temperature, and tastes, and everyone is becoming impatient. And Torella points out that feeding problems in preterm infants create a risk for early interaction and communication difficulties, which is part of what we're going to talk about in part 3. So there is one study conducted by Sue Horner and her team at Lurie Children's Hospital that was done using the SOFFI method, and they actually looked at outcomes both at discharge and post-discharge. So I just want to end this section with this study. You see that they have a tertiary level NICU with approximately 600 admissions per year. They have both preterm and full-term infants in this study, and they had a convenience sample of 81 infants before SOFFI training, and then they enrolled 75 infants post-SOFFI training after a period of time where they validated that everyone was using the algorithm correctly. Infants were included regardless of most illnesses or medical diagnoses, and nearly 2/3 of both of the cohorts, pre and post, had neonatal morbidity index scores of 4 or 5, and the groups were not significantly different. They were able to achieve 128 post-term, post-discharge parent phone interviews. So at NICU discharge, there were not a lot of differences, really. The only statistically significant difference was the interval in terms of days to full PO feeding was shorter for the preterm infants. Length of stay and growth were similar. Where they found more of their differences was actually 3 to 5 months post-term. When you think about feeding skill development, it's very important to remember that around that age, infants begin to move out of feeding skills that are driven by the central pattern generator and into feedings that are volitional. And as they make that change, and that change comes as early as 2 months post-discharge, according to the Torella study, as they make that change, sometimes that's when infants begin to show more rejection of feedings. And what they found in the post-SOFFI grouping, the percent of infants that were reported to have feeding problems was lower, arching with meals was lower, spitting and vomiting was lower, and parents reported that their children were seeing a feeding therapist less often in that cohort, and those are all statistically significant. So what I like to wrap up this section with is really thinking about the feeding as a process. And one of the things that we're going to be talking about in part 2 is we'll be moving towards how each of us as clinicians can use this information to inform our practice. Also thinking about how do we bring into the mix the role of the parent, because the parent and child interaction is critically important. There's nothing that we do with our infants more frequently than feed them across the whole first year of life. And so we really want to be able to support that parent-child interaction. And so far we haven't talked about the role of the parent in terms of being the feeder. It's not easy to keep up with literature when you're a bedside clinician, and this information also isn't easy for many people to understand. It's really an exciting time for us with lots of wonderful people who are doing research in this area, and I'm hoping to provide time to pause and consider what we need to do to push things forward. What are we as clinicians doing to support infants and families? And that's what we're going to reflect upon in part 3. Thank you very much for joining me.